I'm Dr. Ryan Kazemi, and I'm glad that you can join us today for our complex case discussion series. I'm delighted to have two of my dear colleagues as our panelists today. To my right, Dr. Brian Gray, general dentist in Washington, D.C., who I've known for a very long time. We have done much great work together, and thank you for being here. And to my left, Dr. Nagar Sagafi, an orthodontist, practicing in Bethesda as well as in Spring Valley. And thank you again for your time.
Thank you.
Today, for the case that we're going to discuss, all of us have interacted and worked on this patient. Now, this patient particularly is been in the treatment plan phase and had just recently started treatment. But we felt that it would be a great case as a discussion, and we'd like to share that with you. So let's go ahead and start. I want to give you some background. Again, the patient history is that a young female who had suffered a fall. She was seen in the emergency room for repair of some gingival lacerations. And tooth number 8 had a 3 out of 3 mobility, and tooth number 9 with 1 out of 3 mobility. And there was an incisor fracture on tooth number 7. She also had a through-and-through laceration of the lower lip, which was repaired at the same time. Now, the first imaging that was done was a cone beam CT scan, which is really kind of crucial to have in any type of traumatic episode, really to look at the roots, the foundation, the structure in the bone, to have obviously a more accurate diagnosis of the nature and the extent of the injuries. And she had a dentoalveolar fracture. Here we can see that there is a buccal plate that's been displaced. Again, this is tooth number 8 that had a 3 out of 3 mobility. And as part of the initial management, the tooth could not be salvaged, so it was extracted. The buccal plate was preserved. It was reduced in a closed fashion into position, and a site GBR was performed. The gingival lacerations were closed. The lower lip was also repaired. And following this, the patient was referred for endodontic evaluation of teeth numbers 7 and 9, since both of those teeth had suffered or were involved in the trauma. And she was advised to follow up in 2 or 3 weeks. And here's the closure of the laceration. She was seen about a month later for the treatment. Both teeth numbers 7 and 9 were treated, non-surgical root canal therapy by one of our great colleagues, Dr. Piruzia. And subsequently, patient returned. In about 4 months, we saw her to discuss the possible plans for replacement of her teeth, tooth number 8, as well as management and treatment of the other teeth. So this is how she presented at 4 months. This is a time that she actually had seen Brian prior to that for fabrication of a transitional prosthesis. She had been given an Essex appliance that she was using for some time, and this is when you saw her. So tell us a little bit about what your take was on that initial meeting.
Thanks again for having me here. It's a great chance to talk about a really fun case that we're actually going to be able to look at and kind of grow together. You know, we'll get back together and look at our progress down the road with it. But this was a traumatic event. Madeline had taken a bad fall, and she had fractured off that big chunk of bone that we saw there. That, as we mentioned, I think back, and I was looking at the images, and I was thinking back, 20 years ago, we would try and diagnose that with an X-ray, and just like how tragic, to do something like that and not know whether or not something would take or whatever. And we've got all this stuff at our disposal, and we were able to use a lot of it with her, which was great. Mm-hmm. So we went with an Essex because we like to stay off that soft tissue. It's kind of an easy sell these days over a flipper because everyone's familiar with Invisalign. We just say it's like Invisalign with some teeth in it.
Very much so.
You know, so they're comfortable. Does a good job holding. You know, it gives us a little bit of stability as far as the splint effect is concerned. And it gave us a chance to just kind of talk about what she would want to do. And she had a bunch of things going on, right? That aside from that, we'll look at these photos in particular. We noticed that her hygiene wasn't the best. You know, wasn't really adequate. And part of that was that she just was a little bit wary of wanting to even kind of touch up in that area. And you know, it was one of those chances where we're able to say, hey, actually, just the opposite. We need to have you really keep this clean. And we'll talk about it a little bit later, and Nagar will kind of refer why, actually, that's going to be really important. But at this point, we discussed different options with her. We said, okay, you know, now that things have healed and that lip lesion in particular, which just looked so well, you look at the picture on the left of your screen there, and you can see just how well that has, you know, healed up for her. I mean, the thing that sticks in all our minds is looking at a pair of suture scissors going all the way through the lip and coming out the other side. I mean, that's how traumatic it was. And so to be able to get this closed up and have it look the way it does, and this is old too, it looks great now. So we're able to talk about what we could do. And we really kind of discussed kind of 3 different options for her as far as being able to look at the restorative aspects of this.
Yeah, so this was obviously a very aesthetically challenging case for the following reasons. I think we both appreciated that there was loss of papilla, significant recession on the mesial number 7. There was some vertical loss, of course, on number 8 area. And we can kind of appreciate the insufficiency of the soft tissue, as we see here. There was also a horizontal vector into the deficiency, and we can appreciate that from the buccal aspect. So when we looked at the cone beam CT scan at this point, what we noted, most important aspect of what we saw was the loss of vertical bone loss on mesial aspect of number 7. So the inter-septal bone had migrated more apically, and we can see the difference between the mesial aspect and the distal aspect of number 8. And this is obviously will change the game plan, both from bone, soft tissue, aesthetics, everything that we'll do would really be affected by that. So this is how she came in, and this is where she is right now. Treatment considerations.
Well, there's you know, a bucket full that we want to keep in mind here. Obviously, that buccal defect is one thing that we need to pay attention to, because that's going to determine what we'll be able to do to as far as placing an implant for aesthetics or for restorative. And then, of course, the big defect on the lateral incisor also. And as we have discussed in the past, our good friend Keith likes to say, bone sets the tone, but tissue is the issue here. And we end up with this big defect that if we go ahead and restore, and we aren't able to actually capture back some sort of papilla or something that's going to look natural, and she ends up with black triangles there, you know, it's almost like it becomes disappointing for the patient. So, so we look at that. We looked at the fractures themselves, and then we look back at kind of the stuff where we started, and that in particular is her occlusion. So yeah, you know, we know that the lateral fractured on that edge there, but if you look at the lower lateral and the position of it, it was bound to have something happen. It was probably thin and weak on the lingual surface anyway, just because of where that lower lateral incisor was. So this is where now we have to introduce the potential for an orthodontic component and say, hey, you know, we could fix this and we can make it better, but have you thought about putting the teeth in an optimal position so that we have a better palette to use for our painting, for our work?
Right, and I think this is such a optimal time to have this conversation before investing the time, energy, and of course money into this treatment. for creating the aesthetic outcome, but now is a great time to at least have the conversation about the occlusion. And I think that's something that I'm glad we brought up, and it resonated with her.
Yeah, she, you know, we'll talk about our treatment options in a little bit here, but, you know, when we had this conversation, at first she was like, well, I don't know if I ever noticed anything before. And that's kind of classic. You know, they don't realize the lower anterior crowding that happens as they get a little bit older. They're still thinking of their teeth the way they were when they went to prom. And we look at it and say, yeah, you know, it's not something that might be as visible, but it's something that is functionally in the way. And if we don't address it, we're not going to be able to get the aesthetic result that we really like.
And that's kind of leads us to the problem list. We have significant recession on number 7, aesthetic issue, as well as perhaps functional and longevity factors of that. Interproximal height of bone, a class 3, we'll discuss what that means. Vertical and horizontal insufficiency in site number 8. We do have a thin zone of keratinized gingiva, which will be a factor to consider later on, as well as lower anterior crowding. So this led us to some treatment considerations, and part of that, you know, we always look at the biology to guide us, anatomy, biology, and that really helps us to start to understand what are the limitations and what are the opportunities in managing a case like this. So if we kind of look at the importance of the interseptal bone, not only from standpoint of implant placement and bone grafting, but also from standpoint of creating the normal papilla, especially in the aesthetic zone, which is crucial. So this is a classic article that my good friend Henry Salama, along with a couple of other clinicians, they talked about the class 1, class 2, and class 3. Class 1, interproximal is the optimal prognosis when we have 2 millimeters from the CEJ. In class 2, it gets a little bit more apical in this case, with a little bit more guarded prognosis, about 4 millimeters from the CEJ. And then we have class 3, which is a case for this patient where we have greater than 5 millimeters from the CEJ. And if we kind of look at the importance of that, by looking at the table 1, it really kind of starts to correlate to what we see clinically. The predictability of regenerating the interdental papilla directly is impacted by the location of the interseptal bone and the distance from that to the contact point. And we can see the different restorative environments, and these numbers are relatively accurate in terms of guiding us in understanding this. So, so we considered what are the treatment options. I think as we talked about what are the things that we can do, there were 3 options that became apparent. The first option could be bone graft number 8, restore the vertical and horizontal deficiency, place an implant. And is it possible to perhaps do a coronally repositioned flap, a gingival graft, try to address the recession? How do we feel about that?
Well, I think our biggest concern was that even with maybe being really optimistic about coronally repositioning some tissue on number 7, on the lateral, we weren't sure how well we would be able to get something as far as long-term would be with that. And we presented that because, once again, that would create, in essence, a defect there that becomes something that their eyes go right to, right? It becomes an unsightly thing.
Yeah, I think the question is whether or not how much of a coverage can we actually get? Can that be improved? Probably. The question is, with the location of the bone and the interseptal bone, just how sustainable and stable it is over time. And I think that we all agree that it's may help, but it won't be ideal as regenerating it to a normal level that we intend to. The option number 2 was considered, and this was the forced orthodontic eruption on number 7. Try to migrate the apparatus, the attachment apparatus, more coronally, and then site development on number 8, place the implant on number 8, and then reevaluate number 7 to whether or not keep it or not, depending on its stability and how much of the root remains in bone. And we'll talk about this in a few minutes. The option number 3 was if the patient is not aesthetically concerned, or it doesn't bother them, or perhaps if they have a very low smile line where they don't see it, but certainly, one can leave it. That's obviously a patient's preference, and you would just basically do a site development number 8 and replace that with an implant and restore. But obviously this was a concern and not something that would work in this case because she wanted something better. Her smile line is not low, it's not very high, but you do see that papilla. She has a relatively normal smile line from what we assessed. So this really became our first sort of a preferred way to address this patient was a forced orthodontic abruption. Try to migrate that attachment coronally and see if we can regenerate and normalize on the level. I'm going to turn that conversation to Nagar in a few minutes to tell us a little bit more about this technique. But I just want to share a case with you. This is a relatively recent case. A patient who had traumatic loss of the 2 central incisors, had 2 failed attempts at bone grafting. It just didn't work, infection, and it resorbed. So when I first saw the patient, there was vertical deficiency quite a bit. We discussed bone grafting to restore the vertical and horizontal defect. But as we can see here, we had a similar issue. The inter-septal bone on tooth number 10 had migrated more apically. And as we know, the level of bone grafting that we can do is set or limited by the level of the inter-septal bone. So if that's where the inter-septal bone is, this is pretty much as good or as low or high of a bone graft that can be done to correct the vertical insufficiency. So the idea that we discussed was, what if we try to do a forced eruption on number 10, purely to try to get that inter-septal bone in a more even level, because then we can create a more complete vertical augmentation and put those implants in a more ideal position. So this, this slide shows the orthodontic eruption after it was completed. We're able to actually get maybe about 1.5 millimeters to 2 of eruption of that inter-septal bone. Next, and this is again the direction of the eruption. This is immediately when that was completed. The next level was to actually do the bone grafting. I performed this using a 10th screw and GBR technique, utilizing a non-resorbable cytoplast membrane, a titanium reinforced membrane. We allowed this to mature for about 7 months. And when we came back, we were able to augment and redevelop the vertical deficiency to a better level. There is still a vertical insufficiency on the tooth, but it's certainly improved. And this patient is actually in the process of the implant placement and restoration. But I think we can appreciate that we have corrected to some degree our deficiency on number 10 area, and hopefully it'll help us with a better aesthetic outcome. So this is a case to just demonstrate this technique. Now, what is the treatment sequence? We kind of go through this exercise by really trying to understand where we at and where we going. So one of the tools that is quite valuable in the 2-dimensional smile design to try to give us a sense, and also to help to educate the patient in terms of their teeth and the aesthetic concerns, tissue insufficiencies. And I'd like you to maybe talk a little bit more about how you use that in this, at this stage of the treatment.
I think one of the most powerful things about just even a 2D smile design, which we're showing here on the slide, is that we get a really great idea about soft tissue aspects of the restorative case as well as the hard tissue. So we know moving teeth around, we know about the prosthetic result that we may be looking for and what we're going to do to accomplish that. But when you put the teeth silhouette on this smile, for instance, you know, immediately I can look at everything and say, yeah, no, number 7 has got this big defect. And if someone's taking selfie pictures or whatever, boom, the eyes are going to go right through that. So she can see this and visualize this now, because without something like that there, they can't appreciate it as much. And it's so easy for all of us to do this nowadays, to just slap a grid on there, be able to look at it, and then now apply the face. If we add the face, now we can look at and determine whether or not they'd have a high or low smile line. What's the gingival display that we're seeing? Is there any cant in the arch that we need to consider? Are the teeth actually inclined in the face? So we take those things into consideration, and now we can have a discussion with the patient about what the ideal options are. Sticking with, you know, what we always do, form follows function. So we need to have that nice, strong function first. We need to put the stuff in the right place, then we can do the restorative aspects of it.
Yeah, so it's just a great, simple tool and a quick way to not only demonstrate to patient about the possibilities, but also the emotional dentistry aspect of it. And I know we did 3D printing and being able to do prototyping from 2D optical scan, creating a try-in without touching any teeth. It really sort of takes us to an exciting level. And I think this is something that probably in orthodontics and smile design is quite familiar and to you guys.
Yeah, absolutely. We have to do all those evaluations quickly as you're designing, moving teeth around, and you have the opportunity when you're doing orthodontics to do that. So it's just a different way of approaching it. Exactly.
So anyway, so this was just a quick 2D design. And this is when we recommended that why don't we explore the orthodontic evaluation to address not only the occlusion, lower anterior crowding, but also to see if we could restore bone soft tissue in that critical area. So we asked Nagar to take a look and give us her expertise and help us figure this out. You saw the patient, and you can hopefully tell us what your thoughts were.
Absolutely, and like you both have said, it's an exciting case to be able to be involved in, so thank you, both of you. And it's been really nice to get a sense of what she's going through, and this is an emotional situation. Obviously, it's trauma, it's in a very aesthetic zone, so we're all trying to really put our best hat on for her and see how we can make the final outcome most aesthetic and also stable for her. And so the option we've decided to go with is orthodontic extrusion of number 7, for the main reason of making sure that the inter-septal bone on the mesial of number 7 is leveled with the area where the implant is going to be placed. Because of everything that Hami just discussed, obviously that's going to put us in the best shape. And the technique of doing orthodontic extrusion, obviously, as you know, there's 2 different kinds. We can do it quickly in terms of crown lengthening if we're trying to do so that the bone doesn't follow. And this is exactly the opposite, where we are looking for the bone to follow because we want the papilla to follow. We need that soft tissue to come along with it. So this is a process that takes longer time, minor movements over a longer period of time that are very controlled, and the amount of force that's used also needs to be very minimal. Within a setting of a very sterile environment that Brian alluded to in the very beginning, that her hygiene is not ideal, particularly around that tooth, for the reasons of she's trying to sort of avoid really much contact with that area. So it was key for her to understand, and she's really at a great place with that now, that we need to step up the hygiene, and Brian's office has really been on top of that, your hygiene team, and she looks excellent. And so that's why we've started the treatment for her. So on the lower, you'll see, you know, in the upcoming slides that we've started the treatment, but the case is dependent on getting that number 226 also that you talked about in alignment and out of a traumatic occlusion with number 7. So basically the treatment starts on the lower while we stabilize the upper and get the hygiene under control, and intrude number 26, turn it around, get everything lined up in preparation for the upper.
Okay. So let's talk about this technique a little bit. There's a couple of articles as a reference. A group, this was a paper from clinicians from Korea, Kwon, Yoon, and Chen, who discussed how much of an eruption can actually be achieved using this forced eruption technique. And what they noted was average of about 1.36 of bone level changes, a little bit less from the gingival level, about 1.09. Does this sound pretty much consistent
Yes.
with what your experience is?
Yes, absolutely.
Okay.
And you know, these techniques have been studied and have been around. You know, the Salama group started in the early 90s for multidisciplinary cases, and it is consistent. It's slow. You have to be patient, and it's doable.
Right. Yeah. Another paper that one of my good friends, Ernesto Lee from Penn, who had discussed or presented this case in an article. This patient had a very severe bone and soft tissue insufficiency, and he utilized the forced eruption along with bone grafting techniques to try to correct this defect. So here is how he developed the scheme for the forced eruption. He was able to bring down the attachment apparatus quite a bit. And then once that was completed, he performed the SMART technique for augmenting the vertical deficiency, ultimately implant placements and restorations, and really a remarkable result and outcome from such a severe insufficiency. The problem with trying to graft that type of site without adequate soft tissue and bone is extremely difficult to get that type of vertical augmentation, as we all know. So by virtue of dragging down this bone, he's also developing the soft tissue, which is crucial for the bone graft to work. So really nice paper. Another paper by Henry and Maurice Salama, where we had talked about the role of the orthodontic extrusion remodeling in the enhancement of soft and hard profiles before implant placement. Really, the concept is that we're taking a type 2 defect, we're transforming a type 2 defect into a type 1 site. And so by exclusion of the tooth, the apparatus moving more coronally, essentially we're converting it. And this is really the idea behind this approach. So with that in mind, knowing that we were going to go with the orthodontic stage first, one of the things that's very easy to do at this point is planning ahead. Planning ahead for the bone grafting, way in advance, knowing that at some point, once we have optimized the soft tissue on bone, that we're going to have to cross this bridge. So one of the questions is, do we have sufficient bone and more importantly, do we have sufficient bone in the right place? Because the first glance at the cone beam CT scan showed that yes, there is good thickness of bone, even though we notice that there is a horizontal deficiency. But the question is it in the right place and is it adequate? And it's really impossible to know that without doing a virtual workup. So right off the bat, we can do an optical scan, use our CT to merge the data, and now we can do a virtual implant placement and a virtual wax up of the planned tooth on number 8. And what we were able to notice right away is that there is deficiency of bone on the buccal aspect. So we know that for longevity, for long-term success, both aesthetically and functionally, we need bone, we need soft tissue. We need that implant in the perfect place, and an abutment and restoration that follows biological principles. In fact, we can also see that because of the orientation of the premaxilla and the tooth, that we might be looking at a cement retained position for the implant. This is good to know way in advance from an aesthetic standpoint. And whether or not we want to do screw retain, use an angle channel abutment. These are all the conversations we can have way ahead, even before we get there. Pretty remarkable to be able to do that.
I just got to say, kind of going through this, that this is the standard of care nowadays. I mean, if we have the capability of doing this for someone, there's absolutely no reason why we should not be doing for something like this for someone who loses a tooth to some sort of trauma or whatever in the aesthetic zone, just because of the picture on the right, the diagram on the right shows us right now, hey, where does the implant have to be placed? Do we have to place a screw retained, a NASCAR angled abutment, or is it going to have to be cemented? Which is going to change everything as far as the prosthetics is concerned. We're looking at this before we've even started. How lucky could we be? How blessed could we be to have this? So it's a great option for us to be able to look at it and know what we might have to do.
And the other great benefit is that now we can inform the patient and they're aware of it. It's not going to be a surprise, 6 months, 7 months down the line that, no, sorry, we got to do a graft now. This is all presented way in advance. They know what they're getting into, and we have a long-term plan. So it's really valuable from every aspect. So the sequence was the forced eruption. At some point, once we correct the deficiency, bone graft, implant, and the restoration of numbers 7 and 8. Connective tissue graft along with implant, always, almost always, especially in the aesthetic zone. Thicker tissue biotype, we know from many studies, observations, many clinicians have published on this about not only the aesthetic benefits, but also protecting the bone from resorption and from remodeling, and that's part of the equation. And then the question of what we'll do with tooth number 7, whether or not we'll keep it, or perhaps not be stable enough, and maybe consider doing partial extraction therapy, which is an amazing option to have. This particular case would be a submerged root therapy for pontic site development, soft tissue management, and that's something that we can explore. So going through the steps of how this case is now planned, first we're going to go to ortho.
Yes.
We're going to wait. Walk us through about the steps, timeline, and how you actually do this.
Absolutely, and I think maybe our next slide even shows like her started in braces. So she's basically in braces at about 8 weeks right now, and you can see her hygiene is impeccable, and she's doing an amazing job on the upper while we've started the lower. So this is going to be lower, just limited treatment with interproximal reduction. Number 26 is already starting to turn around, and you can see that there is already an interocclusal space between 7 and 26, just automatically removing that trauma. The idea is we want to start stabilizing 7 as much as possible so that we set ourselves with the best success when we start moving the tooth in a sterile inflammation setting. As you know, orthodontic treatment is taking advantage of an inflammation that we're causing. So in this case, our progress has been really good so far on the bottom, and the idea is in the next couple of visits, which basically could be in the next 2 to 3 months, I'm going to start the orthodontic extrusion on number 7. She will have somewhat like we can do this always in quadrants or in segments. You don't necessarily need to get onto the whole system. For her, I am going to go from second premolar to second premolar. We need to use the other teeth as anchorage, which means the bracketing has to be perfectly passive. Then we want to get a stiff wire on those anchorage units while we have a very light wire working that extrusion of number 7 in that sterile environment. The idea is what we're hoping is 2 to 3 millimeters of inter-septal bone that we're going to bring along with the apparatus. So as you mentioned earlier, we're looking at about 1.39 millimeters, so per 3 months. So we are looking at a 6 to 8 month period probably, and as the tooth is extruding, just doing incisoplasty. It is endo-treated, as you know already, but to make sure that it's not in occlusion as it's extruded. And once we get to the point as we're progressing and evaluating and see how much bone we have, then comes that question of what are we doing with number 7, But until then, leveling that interseptal bone plane is the plan, and I'm optimistic. So we'll find out together.
Do you use full arch stabilization when you do this?
You can, and you don't have to. It all depends on where you're extruding, which tooth it is. You know, if you might be on the lateral side and you might just do a segment, you know, as long as you can have enough units. And in her case, because we're right in that aesthetic zone, we're going to be crossing the midline. I want to kind of have a, you know, a very harmonious appliance on for her. So nothing asymmetric, just so the eye doesn't catch that.
So it'll be interesting to kind of see, of course, the amount of soft tissue development that we get. It's quite possible that we may not be able to get 100%, and I think we have to be prepared for that. But I think we can fall back on the coronally positioned flap soft tissue revision and grafting, but the difference will be smaller to make up. So we'll still have that as a surgical solution to try to complement what we'll get from the orthodontic eruption.
Yeah,
well, I think this is the wonderful thing about the collaboration. You know, when we have a multidisciplinary approach, and we strategically treatment plan, so we're going to go to the end result, which for us is always the same: beautiful, healthy, functional smile, and then work backwards towards where we are right now. So we look at these contingencies. So we're talking about all of them right now and putting them in our plan so that if X happens, well then Y. And the patient knows that. That gives a tremendous amount of confidence to the patient as well, too, that we've thought these things out. And one of them that we haven't even gotten into yet is, what about number 7? Say, what do we do if we get it and we, you know, to the point where we're getting some great bone, but now we don't have a great crown to root ratio. Yeah. So what would we do? And we discussed that as well.
Yeah, I think in that case, if the tooth is guarded with the ratio as you talked about, maybe more mobility and long-term prognosis is not good, then of course we would have to consider removal. But again, to preserve that bone and soft tissue, using the submerged root therapy is a fantastic way to do it. And we can do pontic slide development and create the papilla and the gingival silhouette that we're looking for.
And if we choose to keep that number 7, you know, depending on what we find, even with the reverse crown to root ratio, we know post-eruption we're going to have to stabilize the tooth. Wait for another, you know, 4 to 6 months. We might put her in a fixed retainer, just something extra coronal, just to help with that stability. And we know from Amsterdam's, you know, studies with the reverse root crown ratios that patients can maintain their teeth for a very long time when we have splinted teeth together and really great hygiene. So circles back around to what you were saying. We're looking at every aspect. What can we do? How can we move forward as things develop, as our work develops for her?
Classic perio-pros principles of preservation of teeth, which, as much as we love implants, I think we gotta stay give as much attention and love to keeping teeth.
Exactly.
And I think it's possible in many cases to do that. We don't have to compromise by jumping the ship in those situations. So the surgical plan will be, of course, at some point the bone graft. In this case, the bone graft technique that works quite well. Again, this is mostly a horizontal insufficiency. The vertical will be corrected to some degree. Using a guided bone regeneration technique is a very effective way to increase the 3 millimeters of horizontal augmentation that we're looking for. This is not a severe deficiency, it's relatively mild. In fact, in cases like this, we might have the opportunity to do a smart graft. Certainly the tunnel technique is quite conservative because we don't want to disrupt the soft tissue by making more incisions and flaps. So this can be done in a more tunnel technique to do that. There's also the possibility of osteodensification, expansion of the bone, and in conjunction with some sort of a tunnel technique to do GBR to really kind of give us that horizontal vector. Again, minimally invasive techniques as much as possible so we don't have to raise a flap, because every time we do that, something will give. There's going to be remodeling, there's going to be some response from that. So that remains to be seen, and we'll evaluate that. Once the bone is augmented, we will place the implant. The question always comes up as to whether or not you can do the implant and grafting at the same time. There are times that one can do that, but I subscribe to the one miracle at a time philosophy. Building a foundation and doing the implant once the site has been developed, much more predictable, less risky, and I think the addition of the time, overall treatment time, is not really something that patients object to. They want results, they want stability as what we want. So doing a stage approach is certainly safer. Soft tissue graft, always to convert the tissue biotype. Not unusual that after trauma and certainly procedures and other techniques, that the soft tissue does go through atrophy, it does thin. So we have to create or take advantage of every opportunity that we can to augment the tissue thickness. So at the time of the implant placement, doing a connective tissue graft to augment, that's one opportunity. There are times that we can submerge the implant, and then at the second stage, during the implant exposure, that gives us another opportunity to do a palatally positioned incision and roll that tissue toward the buccal. So that's two opportunities to build up the tissue and help us with our aesthetic outcome as well.
What's beautiful with everything that you're just describing from a surgical standpoint, as a surgeon, what you're able to add with the bony changes and with the tissue changes, the orthodontic comparison that's going to kind of dance along with what you're doing is sort of using what you were saying, nature and Mother Nature, because with moving, the tooth down coronally, we know the osteocytes producing the cells, and we know the stabilities. The studies have shown, with Salenza, that bringing that bone just naturally, that the lacuna that are producing during the resorption and apposition of the bone just during this process. So the site development is going to add orthodontically, and then as needed, and you're continuing to develop that side for the hard tissue. And the soft tissue the same. As the papilla is coming down, and the papilla that you're going to be working with, the soft tissue, as it continues to go through those changes, with the orthodontics, it's going to be red initially, it's coming down, it's non-keratinized as it's moving down, and then it starts going through those 28 days of keratinization, going back to our basic perio that we were learning in dental school, and sitting in the back row maybe going, when is this class over? But these are all coming into play, and it's just really, I'm enjoying listening to you with the surgical portion of it, and sort of seeing in my head the orthodontic portion of it, and seeing how it can all really just work well together. Yeah,
absolutely. Yeah. Last but not least, evaluation number 7, we talked about that, possible submerged root therapy, Pontic site development. And this is where the surgery becomes kind of the bridge between the surgical world and the restorative world, which is always bridged. And how we can sort of start to design the soft tissue and the gingival architecture through prototyping. So at some point with the implant, we're going to start to have the conversation about provisional restoration, one that I like to call a prototype, and that's where we start to really design, and the restorative aspect comes in. And the restorative aspect, speaking of, what's on your mind?
Well, once we're able to start that phase, one of the things that we're going to do is coach that tissue to the most ideal level possible. So we have to, when we look at the picture that we're looking at right now, we have to imagine where we can get that gum on the lateral, where we can get that down to, and then what can I do prosthetically to help support it, and actually to maybe help it grow, so to speak, to help give her papilla where we need to. And we'll do that over a period of time that may take a few months to 6 months to maybe even longer, depending on what we're getting with the maturity. The nice thing is we've had this discussion with her. She knows about it. She's aware of it. Our visits are super easy. I love doing those visits too. I love being able to take that temp out and look at it with it in. We take photographs and we'll throw a grid on there and immediately look and see what we've gained or what we want to change. Then how do we do it? Do we want to bulk out the contour a little bit to give us just a little bit better zenith maybe, or is it over bulked? Or do we want to go out a little bit laterally so that we can give better support? It's part of the fun of being able to do this. So we're looking forward to that aspect when we get there. And she's aware of kind of all those different options that we've talked about.
That's great.
Now, the exciting area about this aspect is that with the digital workflow, one of the things that we've been testing, conventionally or traditionally, it was quite difficult to go from the implant placement and to the provisional restoration and try to design the tissue. So one of the things that we're doing now and testing in our digital laboratory is by placement of the implant, scanning the implant right away, and then sending it to a design software and actually designing the prototype restoration. Or if we don't want to load the implant for reasons of not having the primary stability, to fabricate a customized healing abutment, which is really kind of exciting because now with a customized healing abutment, we can start to form and design and train the tissue from the get-go. And maybe the patient will have an Essex appliance through the next 3-4 months of integration process, but we have not compromised on that opportunity to train the tissue. So this process used to be quite difficult, long, hard, and expensive to do. But now this can be literally turned around in hours. So it's an exciting area where from a surgical standpoint, now we have to start to thinking about or think like you guys and start to get our restorative mind in place, but really kind of have that opportunity to bridge a gap and make things better. So I know you're all over this.
I am so excited, you know, just with all the ones that have come out. I got to tell you, it's just crazy. And we, you know, thinking back to the old tomato on a stick implant, you know, oh my God, why not start developing the tissue right away? Why not, once you have the implant in, start to train it and govern it to where you want it to go instead of having to go back in. And as you said, every time you go in, you know, you're affecting vascularity, et cetera. So we're able to actually guide that to begin with. And now, as you know, like some of the Inter-septal and some of the others out there where we're able to actually build the scan into knowing what that's going to look like is going to make, I think, just over the next year, it's going to be really exciting. So. Yeah. Hopefully we'll have some of those things to share when we get to with Madeline's case.
Yeah,
sure
so we'll continue to document her case moving forward, and we hope that we have the opportunity to present the progress as we move forward. Perhaps in one of our future episodes, perhaps we'll gather and present that part as part 2. And it'll be exciting to see if these concepts persist and help us get there. Well, I just want to quickly thank you guys for taking the time to be here and sharing your thoughts. One of the exciting things about the conversations we've had, and we've done this off camera, and this is exactly the real world life. This is it. This is what we brainstorm, we talk, we crunch different perspectives, and to be able to kind of bring that and share it with our colleagues is just such a valuable contribution. I thank you both for being here and allowing us to do this.
Same here.
Thank you, Brian.
So much.
Thank you, Nagar.
Thank you.
I look forward to having you guys down the line. Okay. We're going to continue this case. Just to mention, in case there are any specific cases or tough cases that you might be dealing with, feel free to schedule an online meeting. I do get the opportunity to discuss some of these cases that early on during the treatment plan phase. And it's all about sharing those thoughts, so you can certainly reach out to us anytime. That's it. Thank you again. Look forward to seeing you soon.
Thank
Bye.
you.
To be
Bye.
continued.
Yes.